Hi, and welcome to the December 2024 issue of IGIE. My name is Phillip G., Section Editor for IGIE's section on historical considerations. Behind every successful endoscopist is a cadre of talented and outstanding assistants. When I graduated from my GI fellowship at UCLA in 2017, I casually asked for advice from one of my endoscopy assistants, and she casually responded, "Make sure to stay the cheerful way you are. And one day, when you become big, don't you ever forget about us little people who raised you." The advice that was given is one that I hold dear. Once I became an attending, I just made it a habit to do all sorts of little things for my nurses and techs, stuff like getting the bill whenever I see one of them in line at the cafeteria. It's simply the right thing to do, to thank those who work tirelessly behind the scenes and contribute so much to your success day in and day out. I've always looked up to like-minded colleagues who went out of their way to take care of their staff, and among such colleagues, very few have exemplified this altruism on a big level more than Dr. Gottumukkala S. Raju. Widely known to go out of his way to take care of others, Dr. Raju is a pioneer and key innovator in the education and professional development of the endoscopy assistant. In a truly novel way, Dr. Raju successfully developed the first formalized curriculum for endoscopy technician training at the Houston Community College, turning endoscopy technician training into a formal certification program accredited by the Southern Association of Colleges and Schools and the Texas Board of Higher Education. This ultimately culminated in the designation of the week of December 5th to 9th, 2022 as Endoscopy Technicians Week, officially recognized by the state of Texas and signed by Governor Greg Abbott, a first in the country and a historically significant moment. In honor of endoscopy technicians everywhere, we are delighted to welcome Dr. Gottumukkala Raju as our distinguished guest for the Historical Considerations section of IGIE. A passionate educator and a champion for junior colleagues, trainees, nurses, and technicians, Dr. Raju served as the inaugural editor-in-chief for Video GIE and recipient of the ASGE President's Award in 2019. Dr. Raju is currently the John Stroline Distinguished Professor at the University of Texas MD Anderson Cancer Center, where I am proud to regard him as my colleague, mentor, and friend. Dr. Raju, thank you so much for taking the time to do this interview. It is truly an honor and privilege. Tell us a little bit about yourself and your own background and training in endoscopy.
Thank you, Phil. First of all, I want to thank you and the IGIE for coming up with an innovative way of developing the journal that is exciting for young people and also people like me who try to think outside the box. And on a personal level, I'm actually delighted that you came and joined us when you had so many opportunities across the country. I personally think that's probably one of the best blessings Anderson had. So coming to what you said, developing the endoscopy technician training program is a group effort, and a lot of people over the last 10 years worked and developed it. And I enjoyed being part of that group because it was a passion that so many people shared and that they need to do something. And I would like to tell the story, acknowledging the contributions of so many people who made it possible. Regarding myself, I come from South India, from the east coast of India, in a state called Andhra Pradesh. Basically, we come from a farming family in the rich Godavari district, where a lot of rice paddy, known for rice paddy fields. My grandfather was the first physician, actually, who went out from the village to get educated. He was in the first batch of my medical school. We just celebrated the centenary celebrations just this past year.
Wow.
And I had the good fortune of growing up in his home when I was growing up, and being a physician, a general physician who made house calls. I accompanied him, and then watching him actually helped me learn about medicine. But at that time, when he was practicing, there were no medications, not many medications, right? The hand holding that helps. The placebo effect that we all see, I think, is in the hand holding. So, because of him, several people from my family became physicians, and my father is a physician. He's in his 90s, an obstetrician, who taught in my medical school, and who took a keen interest in education. And he had the good fortune of coming to this country in the 1960s to get trained for 2 years in Philadelphia, and then he returned back. And he was a source of great inspiration to me. Now he's 90, he's even getting up early in the morning and tries to read his OBGYN textbook, right? So, those people have played a significant role. And after finishing my medical school, I had the good fortune to go to Chandigarh, where I did my medicine training. And following that, I wanted to work with one special mentor, Jung Dilavari, who was different from the rest of the faculty in terms of his background, in terms of his thinking. He was actually interesting. He went, after his high school, he went to Germany and then did his medical school in Germany, and then moved to England, and he worked with brilliant minds there, and the exposure to Nobel laureates under whom he worked, and also the father of the British Society of Gastroenterology, Sir Francis Avery-Jones. And then he trained with Dr. Peter Cotton and was doing ERCPs side by side at Middlesex. And then he was recruited back to India, to Chandigarh, and he was the first to do ERCP and stone removal in the late 70s, about 1970, late 70s. Mm-hmm. He was fun to work with in the sense that he allowed you to have free thinking. And after my medicine training, I worked with him in hepatology. He was the head of hepatology. Worked with him for a year. I worked 14, 16 hours. At that time, we didn't have much zinc steak and tube. I had zinc steak and tube in my backpack. So when somebody came with a bleed, I went to put a zinc steak and tube. And at that time, there was no banding. All we did was sclerotherapy. We even prepared our sclerotherapy needles ourselves. So when I joined him, he did not allow me to do endoscopy until the technician said, this guy has washed enough scopes and he knows how to handle the scopes before I even touched the scope. I think that was a very good learning experience. So after that, in India, you do your medicine training for 3 years and you get your MD, and then you go for specialty training, and that is called DM. And then I went to Delhi University, and I was very lucky. I was particular about meeting and working under very special people. When I say special people,. Not only what they did, but as special human beings, something that was important for me. I was very fortunate to go to Delhi University, and I trained with Dr. Professor Brewer, who did a lot of work in acid peptic disease. And he was trained in Milwaukee, came back to India, and then Dr. B.S. Anand, he trained with Sidney Truelove. Sidney Truellove's criteria for ulcerative colitis.
Sure.
So he came back. So these two were my mentors. And they were not only fantastic mentors, but they were class act. When you say class act, when you see people at the high end of the spectrum, they compete. But in that competition, they maintain what you would expect a gentleman to be. That is something I really hold dear to my heart. So following my 2 years of training, at that time, there were not many opportunities in India because I wanted to do academic medicine. And you have to go through some state exams to find a job. You don't know where you'll end up. So what happened was my mentor, Dr. Anand, recommended me to go to England to work with Dr. Chandu Baradan. If you actually look into the amazing work Dr. Baradan did, to tell you a little bit, he was a Rhodes Scholar from India, and he did a lot of work for his PhD in Oxford, and he started his career in a district general hospital, despite being a DPhil. And in a district general hospital, you don't have many opportunities to do research. All you have is yourself as a faculty who is in charge of general internal medicine and specialty. So every fortnight you're admitting strokes, heart attacks, pneumonias, pneumothoraxes, everything. And then your outpatient clinic is general GI plus general medicine. So I worked with him for 2 years, and then clinically, and then 2 years of research. He ran a very busy clinical research enterprise. And if you actually go back and look at his work, he's known by Karnadev Baradan, K.D. Baradan, but people know him as Chandu Baradan. Dr. Baradan did the first Tagamet trial.
Oh, okay.
For Governor also, right? And then, from then onwards, everything related to acid peptic disease, whether it is H2 blockers or PPIs or everything, most of the work came from his center. A lot of work came from his center. And being in a district general hospital, the team consists of the chief, the registrar, that was myself, and then 2 interns. That's it. But he was able to do a lot of clinical research, and he has mentored several PhDs from a district general hospital. And for all his contributions, he was knighted by the Queen, and he himself has put in a lot of his earnings into Baradan Research and Educational Trust that supported science research at the university level. So even people from the university were coming to this trust for funding. Wow. So he was, I should say that watching him, you will be surprised if you hear this. He used to have a busy clinic and scoping till 6 o'clock in the evening, and we used to start rounding around 7 or 8 in the evening. And I remember days when I went home at 1 o'clock after finishing the rounds. So, but it was a fun time. I did some research with him, figuring out what's the smallest dose of C13 for urea breath test. And then I finished my membership, but I could not get into London hospitals for further training. So I decided to come here. Cleveland Clinic has been very kind to me, giving me an opportunity to start. And then I went to University of Iowa, where I had fantastic mentors. Bob Summers, who did the first Crohn's and Colitis Foundation research trial on sulfasalazine. And then Jim Christensen. And then at that time, I was a little bit lost. So I was lucky to go to Beth Israel for my advanced endoscopy training with Dr. Ramchitani and Dr. Waxman. And it's very interesting. By the time I came out, you remember Clinton's presidency has influenced what is going to happen in medicine. Right. Not many subspecialty jobs. If you go back to 1997, there were only 3 jobs for gastroenterologists. So I was fortunate to start my career at KU. Dr. Richard McCallum has offered me the job. But what happened was I was there, I started, And interestingly, when I joined there, all the technicians and nurses except one technician and one nurse, everybody left.
Oh, wow.
So here is a guy who's just finished training, comes as an endoscopy chief, and there's no team. So I decided to take classes every day to recruit people and train them. And that has actually helped me, figure out, what it takes to train people. But I was not able to do much research. I was just trying to stay afloat, writing case reports. I could not do any original research. So I moved to Galveston. Thanks to Jay Pasharika. Jay has done some amazing work, whether it is Botox for achalasia or the first poem study. So Jay was kind enough to recruit me and mentor me. And when I came to Galveston, I didn't have any research background. Jay mentored me, and I did some work on this wing stent that they developed to cut down the risk of stent-related damage, to learn how to do animal work. And Jay was kind and said, hey, if you keep putting my name as the last name, people don't think that you did anything. So unless you need me, you should go on your own. I think that was a great advice, because when young people are coming up, it is very important to establish themselves as an independent investigator. And he gave me the opportunity, hey, if you want my name to get your papers published, you can put me. Otherwise, I want you to go on your own. So what happened was it's 2004. And that was the time Tony Kalu wrote this paper about transgastric nodes procedures. And that created a lot of interest. And Dr. Jeff Pansky wrote a beautiful editorial in GIE. And that editorial, he laid down the steps, what a gastrointestinal endoscopist should do to do transgastric or transcolonic peritoneal type of interventions. And among them, he laid out, one is secure closure, right? Without secure closure, we all end up in more trouble, right? Surgeons will hate us for getting into the peritoneal cavity and leaving the open. So I thought that, okay, and around that time I was doing some polyp resections, and one patient came to me with a hepatic flexure lesion that was not big. It's about, 15 millimeters. And I was explaining to him, and then I said, perforation is a risk. And he said, no, I'm going to go for surgery. I can't take the risk. And he was a realtor. At that time, real estate was hot, and he said, I'm not going to take chances. And my surgical colleague, Dr. Guillermo Gomez, it's good to have good surgical colleagues who will work with you. That's very important. And Guillermo used to say, hey, Raju, you're asking me to operate on these patients, a big surgery for a small polyp. Can't you guys take care of these things? So that actually brought this idea that I should work on one project, that is how to close perforations. And I was very fortunate to have the support of Pentax at that time. The leadership of Pentax provided equipment to the lab, including the recording facility. And Dr. Ijaz Ahmad, he's a physician from Pakistan, but he could not get into medicine residency. So he moved with me from Kansas and became my research colleague. And we both worked together to do step-by-step, different types of perforations. Can we close? Can we create a leak-proof seal? What happens compared to surgery? Several questions, over a period of 5 years. That was actually very good, experience to do these things. So that's how, my career started. And we did the last trial, a randomized trial of full thickness resection of the colon and closure you can actually put a T-tack on the other side, like you're doing the traction technique, and you pull that thing towards you and then close. So the full thickness resection and closed defects. My last animal study was done, and then about, I think, 10, 12 animals we did. And all of them did well. Full thickness resection, about almost 2 centimeter resection. And then Hurricane Ike came, and suddenly my life changed. One day I was coping, the next day there was nothing underwater. And then there was financial crisis, and there were no jobs. And although UTMB was kind enough to keep me, at that time the University of Texas had to lay off almost 50 tenured faculty. Wow. 150 faculty, about 1,500 employees were laid off because institution was so badly damaged. And although they were kind enough to say, hey, we will keep you, I felt that if I stay there, I will lose my skills. And despite all the difficulties, Dr. Mendelsohn, John Mendelsohn, our third MD Anderson president, and John Stoline, at that time the division chief, they were kind enough to recruit me. Actually, there was a hiring freeze at that time, and they were kind enough to recruit me. It's not just me. Dr. Mendelsohn, I admire him because he has gone out of the way to recruit so many technicians, nurses, and other people from UTMB. So that's how I ended up at Anderson about 15 years ago. And I've been here for 15 years. It's a long journey, but I was very, very lucky to have really good mentors. And I'm really grateful to them.
And I know along the way, you came to the United States arguably kind of a late start, professionally, if you will. I think you've talked about this personally between the two of us before. And I know you, a lot of the support came in through society membership, through the ASGE. Tell us a little bit about your involvement with the ASGE and how it shaped your career.
Right. So this is important for the fellows and anybody listening. I was so naive. You wouldn't believe this. I was so naive. I was wondering, because my mentors were not active in the societies. So if your mentors are not active in the societies, mentees will not get the benefit. There's a
That's true.
benefit of having somebody up in the society, right? And I used to go to the meeting and then watch, how come this person so junior is able to get onto the stage and I'm sitting here? And I had no clue. And so I moved to Galveston by the time I was 41. Okay, so you're right, 10 years behind the curve. And I give credit to Jay. So Jay was very influential in the societies. He was already some committee chairs in ASGE and AGA. And Jay has put a word to Dr. David Carlock, David Carlock from Brigham at that time. And Dr. Carlock was the president-elect. The president-elect has an opportunity to place people in committees, right? And he gave me that opportunity. And I thank Dr. Carlock for that. So I started in education committee, and there were not this many committees. One committee, education committee, that took care of all the video sessions at the meeting. That's what they did, and they used to help others create the DVDs. At that time, there was only DVDs. And for some reason, videos, I was passionate about watching material. And I must have watched the ASC DVDs at least 2 or 3 times by the time I finished my program. And you remember when you're in a committee, you'll get about, and at that time, we used to get submissions in the regular players, the discs, the smaller discs.
Oh yeah.
Multiple varieties. So we used to try to figure out to have those accessories to watch. And even though I was assigned to maybe 20% of the videos because there are lots of committee members, I watched everything. And I didn't realize that every committee member will be evaluated by the committee chair, depending upon how much work they do. I didn't realize until I became a committee chair quite late. I enjoyed working, and then what happened was while I was doing, Dr. George Phillip, our George, became the editor-in-chief of GIE, and I pitched him the idea and said, "Hey, you're becoming the editor." I didn't know George from Adam, right? He didn't know me either. So I wrote him an email and said, "You're becoming the editor. Are you interested in doing a CME section based on the journal articles?" So I pitched him the idea myself. And I don't know. He just sent me a note and said, "Okay, I want to recruit you. You can do the job." So I actually said, "I will prepare some material, and if you like it, then I will take the job." So I prepared, ABIM type questions. Mm-hmm. I've done so many exams in my life to come here, so you can literally create exam questions. So he liked it, and he gave me an opportunity, and that was fun. Working with George and trying to figure out, like, you have the inner workings of what it takes to produce a journal. Mm-hmm. Every month, right?
Yeah,
it's a great learning experience, exciting learning experience. So, and I was actually, I should actually thank Dr. Peter Kelsey, Brenna Bounds, who actually taught me video editing. And at that time, there was no. They taught me on ULEAD on a PC.
Mm-hmm. Sure.
And I set up in UTMB a system to record video from every endoscopy room, mm-hmm. including the travel cart. So we had a lot of videos, and we gave the material to medical students, residents to edit the videos and put it on the Dave project. Mm-hmm. So as I was doing that. What happened was slowly, as you keep doing work, they'll give you more opportunities to do. And as I was doing the CME, then the society decided to invite me to work and be part of the GSAP, mm-hmm. right? Self-assessment program for ASGA.
Sure.
And I enjoyed that because it makes me read. So we started working on GSAP 5. Every 3 years, you get another one, GSAP 6, GSAP 7, GSAP 8. So I didn't have any other work to do because by the time you finish one, there's another work to do. And one thing is, during my last 15, 20 years, I watched something happening with the journal, the GIE. The GIE's impact factor under George Phillip first time went above 6, right? Mm-hmm. When you go above 6, it becomes a respected journal. And then I've noticed that case reports that a junior faculty can submit was not going to get that much impact. Mm-hmm. It's actually negative for the journal. So the journal has moved away from the case reports, to mm-hmm. maintain that premier status. And I noticed that how is a young guy who's starting his career in a place that doesn't have a lot of data that they can mine, going to survive, right? Most therapeutic endoscopists can showcase their work. And with Peter Kelsey and Brenna Bounds, with the support of Pentax and ASGE, we started the ASGE video editing scholarship program, right? Mm-hmm. Once a year we train with the obligation that they produce videos, right? And Field Willingham, the current editor-in-chief of Video GIE now, was part of that first batch of students in 2006, So, so we are producing video producers, but there is no platform for them, except once a year you show it at the DDW. Right. So, working with the society, we thought that we should come up with a video journal. And the society was a little bit uncomfortable, but for right reasons, what they did was they incubated it under GIE, and then as it was taking up more space in the journal, they decided to float it out as a separate journal. And with the help of Todd and Mike, we started a new journal. So all these things, one thing is I want to share is, we do the work in our hospital systems, but working with a society, any particular society, consistently, you will develop lots of friendships. And you learn a lot watching others, how they have developed their careers. And you actually grow without your own knowledge. And I personally feel that I'm grateful to ASGE. I didn't volunteer for other societies for lack of time. I'm grateful to ASGE because I've grown quite a bit. I learned so many different skills and developed a lot of friends across the nation. And, even recruiting you would not have happened if I didn't develop a great friendship with Chris Thompson, right? These are all things that we don't really appreciate. I fully believe that committee work or society work or voluntary work actually prevents you from burnout.
And I fully agree with that as well.
Yeah,
it's fantastic insight.
Right.
Well, very good. So let's talk a little bit about the assistant. I think we've heard about your background. Let's talk a little bit about the background of the assistant. You mentioned even back in India, you weren't allowed to scope until they trusted you with the equipment. So what was that like? And, of course, just for a little bit of IGIE background, I think, the role of the assistant has morphed tremendously over the years. Started with spouses, like in the case of Rudolf Schindler, to a poor chemistry tech, as with Peter Cotton's Gut Hut. And then it became nurses predominantly, and now there's the modern endoscopy technician. Let's talk a little bit about this.
So, when we practice in an academic center, right, you see this, right? But during your own practice, you must have seen somebody sends a case to, say, for example, Chris, right? And that physician has been doing procedures, even ERCPs, but he sends the case to Chris. And when Chris is doing the case, he's not doing the case. He's asking Phil G to do the case.
It's a dirty secret.
Right? He's going to ask Phil G to do the case. And what is Phil G? Phil G is in the 7th year of his training, post-medical school, right? Still training, but Phil G is able to complete the case. Right? Didn't you really think that, you must have seen that. I've seen that. And I've seen that during my training, and I've seen that after my training in my practice.
Right.
The factor I thought could be that the team, maybe there's a weakling in the team. And that always bothered me during my, when I was in Galveston, I used to get a lot of referrals, and I wondered, hey, why is this? This guy could do this, but why is he sending the patient? And from a patient's point of view, it's 2 bills. Right. So, and after Ike, what happened was we ended up going to community hospital to take care of our patients on a weekend.
Wow.
Community hospital said, you can't bring your team. We will provide the team.
Oh, wow.
Okay. And that was an eye-opening experience for me, right? And when I was, even simple colonoscopies, it all depends upon how you give a biopsy forceps or how you give a snare, how you close a snare, all those things matter. And that actually was stuck in my mind.
Mm-hmm.
So I came to Anderson and been working at Anderson. And when I came to Anderson, most of the technicians worked in one room. And I ended up working with Liban Mahamotano, assigned to me. So I had to train her and get her up to speed. But that thought, why is technician not getting not well trained in a community hospital, affected the outcome, right? That was in my mind. So when I came to Anderson, I thought that, hey, I'll do lots of research, but didn't happen, for whatever reason. Then I started pitching ideas to people for collaboration. I pitched ideas to people at Rice to see if we can do some novel hemostatic agent, whether we can do it for. I pitched ideas to University of Texas in Austin, and from my MD Anderson email, no response. It's like a foreign medical student trying to write a letter to you saying, Dr. G, I want to work with you, and then you just close that thing, So,
oh no.
I said to myself, I want to work on this concept of training. I wrote an email to the chancellor, Dr. Cesar Maldonado. He's the chancellor of Houston Community College.
Okay.
And I wrote an email to him. I didn't know him, and he didn't know me, pitching the idea that surgical techs go through training before they enter into the operating room. 2 years of training. Whatever surgeons did, if you look at last 40 years, varicose bleeding at one time, surgeons used to do portocable shunts or esophageal transection.
Right.
Peptic ulcer, surgeons. Gallbladder, CBD stones, surgery. Colon polyps, surgery. All of them basically are being managed by endoscopists. But we worked with a technician with no formal training in endoscopy.
Right.
A
lot of them are fresh out of high school.
Right. So I pitched that idea and said, could we work together to develop an endoscopy tech training program? So I sent that from my Gmail on a weekend. Within 24 hours, he responded back. That is, I personally admire him for that. He's an engineer, very accomplished, did lots of great work. He's done great work for Houston Community College. And he said, I recruited a new president, Dr. Phil Nicotera. He's joining the Coleman College in the medical center. And I didn't know where Coleman College was. It was in your backyard, and the medical center is just inside the medical center. I had no clue. So why don't you go and meet him? So I actually walked to his office one, midsummer afternoon.
Oh, gosh.
And I introduced to him. At that time, I was video GIE, one of the co-editors. So when you have a co-editor in chief, there is some value, right? So
Sure.
So I said, I would like to work with you. I was very fortunate, and I want to say very fortunate, because Dr. Nicotera, or Phil, is a pediatrician by training, and he became an educator. And he could understand the pains very quickly. And he said, Raju, I'll do my own survey, and then I'll come back to you. So he did his own survey, and all the nurse managers. What is the biggest problem for a nurse manager? when somebody knocks at your door and says, I'm leaving,
Right.
you can't replace a technician. It takes months to replace a technician. Even if you replace a technician, it takes months to train them.
Right.
Right? And when you're doing complex procedures, you can't actually do that. And even if you replace a technician, you are basically robbing a technician from another unit.
Yeah.
And that unit will rob from some other unit, right? If you think about it, it's like a chain reaction. So all the nurse managers said, we want it yesterday. They said, we want it yesterday because we want to replace our technicians because instead of waiting for months.
Right.
So I want to share something that is, okay, by this time I've been working at AEC, giving talks, doing hands-on courses, developing CME material, producing videos. And with all this skill set, I thought that it should be a piece of cake to develop a program. One of the dumbest things that you can think of.
Right.
So he said, okay, we will develop a program. But in order to develop a program, because there's nothing out there, we need to go through a process called DACA, development of a curriculum. So,
Okay.
right? So if you have a particular skill set that is done by a group of people, and you want to create a training course, what they do is they bring those technicians or that special skilled people and put them in a room with the dean for curriculum development.
Oh, interesting.
All right. Community college has the dean for curriculum development and another senior educator. They sat with 12 technicians.
Wow.
2 from MD Anderson, Louis from our center and Kim, and 2 from Methodist, 2 from VA, 2 from other places, like 12 technicians. They sat with these 2 leaders from community college, sat for 16 hours, 2 days. And they asked them, hey, tell me what do you do from the time you clock in to clock out? And they're all bringing different skill set from different hospitals, right? Different things. And then they kept jotting down on these sheets of paper what all they do. And then they were blown away and said, I can't believe that you guys don't have a formal course. Right?
Right.
So they created a big list of items or skill sets that they need, that a technician needs to function, and all the knowledge that is required. Right? You have technician knows certain things, right? The knowledge and the skill set. So the community college president got approval from the governing board, and then they said, hey, we need to create a curriculum and we need to decide. So create an advisory board. So we created an advisory board consisting of endoscopists, nurses, technicians, industry partners. And Kal Patel from Baylor was a key player. Selvi played a key role. And our own technicians, at that time, nurse manager Marcella, Sophia, and Laura, and Lieben, we, along with endoscopy representatives like Tom Slocum and others, we all met every month for a couple of hours for almost 2 years before we could figure out what type of course we are going to create. Is it a level 2 certificate or is it an associate degree?
Okay.
What are we going to teach? So finally, by 2 years, because we didn't know, right? We are not educators to develop this material. The community college helped us, and we created a curriculum, 35 credit hours, 19 credit hours for endoscopy. And that was approved by the governing board of the community college. That was approved by the Southern Association of Community Colleges and Schools, and the Texas board. By that time, my email went in 2015. By the time this happened, it was already 2018.
Okay.
All right. And then you have to create contracts for the students to come and work. Each contract took about 6 months. From a community college to MD Anderson, community college to Methodist, each contract takes that much long for the students to enter into your premises. Okay, all right. And we thought that we will start in 2019, 2020, and COVID came, right? We've all gone through COVID. I promised the community college that I will develop the learning material, and because I felt that they could not do. We as endoscopists, right, what you want your assistant to do, and what you also want your assistant to read your mind, looking at your screen. Correct. And be prepared. That's what the teamwork should be. So to develop that material, I was very lucky. By this time, I was working with Miss Angela Deal, medical illustrator, who was a faculty at UT Southwestern before she became a freelancer. By the time, I was working with her for some time. And then I was lucky to recruit Miss Sanji Suresh. She was a graduate of WashU, taught high school science for St. Louis as part of the Teach for America for 2 years. And she had her master's in education during that time. So these, Sanji, myself, and Angela, we worked on Google slide sets to create the material, and we decided that we don't want students to buy any books. We wanted to create material that is easy for them to learn, and we created everything richly illustrated, almost over 2,200 slides. Right. And Sanji did a lot of lifting. Actually, she knew how to develop material. Right. She did a great job, and Angela did a great job. We were able to complete this, but I felt that we should actually record audio so that the students can listen before they went to class, and then in the class they were taught again. That required a lot of time. When you're working at Anderson, you don't have that much of free time. When you're doing the cases in your clinics, and then the so-called academic time is taken up by patient calls and all the EHR stuff. Right? It's not much free time. And I was doing at a pace that in the evenings and weekends, but I was a little bit worried because I've completed only half of the videos by that time. And then COVID came, and we were shut down, and that actually gave me some free time to complete the remaining videos. So you asked me, hey, how did you do? Did you have free time? And we created about 175 videos. And by this time, I was already, developed a YouTube channel in 2010, posting videos on colonoscopy, and I said I should make it available to anybody across the nation or internationally. So I made it available on the YouTube. By the way, my YouTube channel is not monetized. I felt that education should be available to people. So that's I was glad that I was able to do, so that by the time the students started, they had the entire learning material. It's also interesting that you should learn this. Whatever you do in a particular institution, that material does not belong to you. Right. And I didn't realize that. I wanted to give it to the community college, but I didn't realize that, hey, I can't do that. So the institution wanted to work with the community college, and they wanted some payment. The community college could not afford that. And the leadership, Dr. Bodurka, Dr. Hagberg, and Dr. Pistas were kind enough to let me give the material to the community college free. Only thing is I report back, how many students or whatever. But this would not have been possible without philanthropy support.
Yeah.
Right.
Yeah.
The thing is to have an educator to pay them and an illustrator to pay them.
Right.
And I'm grateful to John Stolan Professorship, which gave some money. And then Mr. Charles Butt of the HEB, another grant that helped. And also a little bit of money came from the Bootwalk program grant. And that was a little bit anxious whether I could complete on time, but having this funding actually made it possible. This was, I'm glad the first batch graduated, second batch graduated, and the third batch graduated this year. All of them were gainfully employed. Some of them are working at Anderson. I'm glad that so far it worked out, and this batch they have 14 students.
Mm-hmm. How many students have graduated total?
24.
Oh, it's fantastic.
Right.
And I know a lot of money went into this, like on the philanthropy side, as you know, like you were mentioning.
Right.
How much did the total curriculum development cost? Yeah.
So I'll give you one hard figure and then another figure that I'll let you put the money on.
Sure.
So the hard figure is it costed about close to, you're looking at 3 to 4 years of support for illustrator.
Right.
And 2 years of support for educator. Roughly around $200,000 to $250,000. You're looking at $250,000.
Yeah.
Plus a senior gastroenterologist time, hours of time.
Right.
That let you put whatever time for hourly thing, whether you want to put $3 per hour.
Academic time.
Yeah.
Oh,
it was fun, but it's very interesting. Community colleges don't have deep pockets.
Right.
And we actually struggled initially to find teachers. Right. But it finally worked out. I think the director, Melissa Bruton, who is the director of the program, has been fantastic to run the program, despite the odds. When you start a program, you don't have endoscopy unit. We had to go out and buy old equipment.
Mm-hmm.
We tried for grants. Grants didn't come through. And so now there is a full-fledged endoscopy unit. And I thank Tom Slocum, who actually brought entire set of accessories for the students to learn.
Wow.
He took upon himself. He played a big role.
Let's talk about that a little bit in terms of the role of industry support in terms of making a program like this possible, right? Like you mentioned, there's a full-fledged endoscopy unit inside the community college.
Right. So we actually, when we started the first batch, we didn't have anything. We had a room that was assigned. And we tried to apply for grants to see, because if you want to develop a unit, it is about $100,000, right? Your processor, your monitor, everything.
Yeah.
And the community college decided to buy some used equipment with their own funding. But the accessories came from Boston Scientific. And then Tom Slocum played a big role because he was there from the beginning, from 2016 onwards.
Mm-hmm.
And he played a significant role in this. And also Duke from OB, played a significant role.
And, it's kind of interesting. I'm sure that professionally, this helps endoscopy technicians quite a bit, right? We were talking a little bit earlier about how the endoscopy assistant has changed over the years. From previously, it was all kind of like nurses.
Right.
And then now across much of the country has become sort of like a dedicated endoscopy assistant. I know that there's some parts of the country, I think particularly in the Northeast,
Right.
that still relies on nurses as endoscopy assistants.
Right.
Actually, let's talk about that a little bit as well. How did this kind of morph from? How did the role of the assistant morph from nurse to tech?
Right.
And because I think that's highly relevant to what we're talking about here, right?
Right.
Because a nurse has a nursing background, arguably a higher educational background, more clinical years under their belt, but at the same time, both nurse and tech, they would kind of both walk into an environment like an endoscopy where they're kind of on a level playing field, actually.
Right.
And they
Right.
both stand to learn the same amount and
Right.
potentially gain the same amount of experience.
Right. 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 So I will share my journey and then reflect on that.
Yeah.
During my career in the U.S., endoscopy nurses ran the room. Whether it is sedation and monitoring and record keeping, one nurse did that, or assisting, setting up the scope and assisting the procedure. Another nurse did that. Two nurses did that. So that was true in the Midwest and also in the Northeast. And by 2000, late 1990s and early 2000, I think ambulatory surgical centers were coming up, and by mid 2005 2010, electronic health records started creeping into the hospitals, and they increased the workload of the nurses in terms of the documentation needs for every procedure, but not only documentation for billing purposes. So that tied down one nurse. And the cost of operation has certainly increased, and the cost of reimbursements have certainly decreased for endoscopy over a period of time. And during this period, people felt that the assistance could be done by a technician, and slowly technicians started coming. And technicians, as they spent time, they became very good. But the hospitals never had a system to recognize the technical skills of a technician and pay them appropriately.
Right.
But there's a difference between somebody doing just a diagnostic EGD colonoscopy versus somebody helping you with Barrett's or ESD or ERCP-US, right? It's a different level of technical skill set required. And endoscopy directors across the country could not convince the HR to pay appropriately for the skill set that a technician achieved. And for the HR, they did not have anything to hang their hat on, right? To say, hey, you have a certificate, you have extra training that we recognize in the HR, and that was a problem. Right, that was a problem when I was an endoscopy director, whether it was in KU or UTMB or even at Anderson. But they do recognize certificates. Right, the community college certificate, level 2 certificate. Actually, now most of the students that are coming out of the program, the director Melissa Bruton shares with me that are getting paid very well with that certificate.
Oh, good.
Okay. Now there is a pathway for technicians to grow. They don't have to stop as an endoscopy technician. Now there is an associate degree with specialization in endoscopy technology at the community college. They can also, if they want to develop business administration skills, from the associate degree, they can go to bachelor's with business administration. And there is that discussion about a pathway from associate degree to BSN.
Oh, okay.
So imagine your endoscopy nurse, who has been an excellent technician for some time and growing up the ladder and becomes an endoscopy, becomes a nurse with a BSN and come back to your endoscopy unit, you have a different team dynamics.
Right. It's a better educated team, and I think,
yes.
From a practical standpoint, I'm sure that has huge implications in terms of longevity, in terms of career longevity and retention, right? Because arguably, with the way things were, nurses, as they were increasingly absorbed into documentation and billing, probably felt like they felt divested from the endoscopy itself.
Right.
And techs, on the other hand, feeling like they were hitting this invisible glass ceiling.
Right.
It felt like this was just a temporary stepping stone. I think what you've created, this pathway, helps to answer a lot of these. Helps to solve a lot of these problems.
Yeah.
Potentially.
Another major development, I think we shouldn't forget.
Yeah.
Is the governing board of the American Society for GI Endoscopy.
Yes.
In 2022, created associate membership for technicians and nurses. First time in the 80-year history of ASGE.
Yes.
Right? So they also created a learning platform, and MD Anderson was kind enough to donate the entire learning material that we developed for the community college to ASGE as well. So they have the learning material on the associate membership platform, and with the help of 10 endoscopists, we created a 400 question bank to test the knowledge, cognitive skill, and the knowledge of endoscopy technicians relating to endoscopy. And the ASGE has so far pilot tested ASGE endoscopy certification of completion. And that's what actually the community college students also take. And the pass mark is not 50%. You have to get 75% to pass. And that has actually helped a lot. One other big thing that the society has done to encourage the technicians and the nurses is, if a group practice joins ASGE as a group member, then that group's endoscopy nurses, endoscopy technicians, their mid-level providers, their PAs can all become associate members for free. Yeah. So you think about the great advantage of what ASGE can offer.
Right.
And our own group, MD Anderson, thanks to Minaz Shafi, Dr. Shafi, they actually paid the group membership, and now all our technicians and nurses are associate members. So they can also they can go there, learn for free, and they can also take the test. That way we create a pathway for people to grow, right?
Yeah.
We all want to grow, right? When you join or I join, we all start as an assistant, we become an associate, then we become a professor or whatever. And the nurse becomes charge nurse, nurse manager, nurse director. Technician, there's nothing. Right? Now there's a pathway for them over a 10-year period, 5 to 10-year period, they can become from a technician to level 2 certificate, associate degree, and even a bachelor's degree.
And as I understand now, there's even alternative pathways as well for those techs who are already employed with experience.
Right. So that pathway is open. That is any technician with 4 years of experience, signed off by their endoscopist saying that they can do certain procedures and pass the ASGE test. They get almost 19 credit hours, close to 19 credit hours, can secure that. And then they can finish the rest by just going online and finishing the courses.
That's
so that
great.
we give them level 2 certificate. That means they're open up to go up the ladder.
Right. Because I think one of the questions that has come up before when I talk about this program in the endoscopy room is, I asked the question, well, what are the pros and cons of going through a formal education, right, via the community college or certificate program? Because, you know, from a technician standpoint, if you can come and become a tech, you start making money.
Right.
Right. So you can make money, and then you would grow and then become a senior tech, etc.
Right. Right.
Versus on the other hand, you can choose to start your career with an official program at like a community college level, but the trade-off there is that there's an opportunity cost too, right? You're paying for education,
Right.
rather than making money for yourself.
Right.
And I think depending on where people are at personally,
Right.
there are pros and cons.
Right. So we are also looking at, or actually Anderson has started this apprenticeship program. So apprenticeship program is, apprenticeship program is where they go to the community college and then they work in a hospital full time, with the hospital providing them free time to go to the community college in the evening for their classes.
Mm-hmm.
And they work for a year. They get a certificate. They have finished the apprenticeship program. So we have one student that we're going to take, who's going to be part of this MD Anderson Cancer Center Community College apprenticeship program. And after a year, they will get very well trained, right? They're working with so many of us. And then if the institution has an opening, I'm sure they'll have an opportunity. If not, this background will help them find a job anywhere.
Yeah. Now, when students, like for example, if you have a brand new student, whether they're going through an apprenticeship program or whether they're going through the formal community college certification program, how do they get actual hands-on clinical experience?
Yeah. So the way we set up the community college program, just want to give you a little bit idea. Mm-hmm. We felt that we should make it a program easy for them to continue to work. So they all are working in the daytime in different jobs.
Okay.
And they go to school in the evening, only 2 days of the week, Tuesday evening and Thursday evening. Most of the learning material, they have it available online as well. But the hands-on simulation lab happens Tuesday evening and Thursday evening. In the first semester, they spend about, I think, 8 hours per week in a particular endoscopy lab. Okay. And then the second semester, they do 2 days of the week. So by the time they come out, they will have the knowledge and the skill sets spread over a period of a year.
I see. And those are endoscopy labs for where they're working, or those are endoscopy labs who are gracious enough to allow them to come?
So these are all partnerships that were developed between the community college and various endoscopy units, typically major centers in the medical center or in Houston. So
got it. A couple of years ago, in recognition of the achievements that you guys have made, the state of Texas actually gave formal recognition to these achievements, and the governor's office signed an official decree, which established a endoscopy technicians week. It's a very well-deserved historical achievement. It's also a very unusual achievement to go that far. Tell us about how this was obtained and what went into that. It's not every day that you see the governor's signature on something like this.
Credit goes to Ms. Jonabel Gamble, our chief educator at MD Anderson for the endoscopy unit. She is somebody who can think outside the box and is not afraid to reach out and pitch for some good cause. She took it upon herself to write an email to the governor's office, I believe, and somehow she was able to convince the governor. And
Wow.
the credit goes to her. I think now she, having come to Anderson, she has put in a lot of effort to train our team, right? Currently she's helping our technicians and nurses go through an intensive 12-week training program. And as an educator, not only she knows how to help educate, but she also knows how to bat for people. I think credit goes to her. Credit goes to Jennifer.
Who teaches these? Who teaches the evening programs and the actual Houston Community College course? I'm just kind of curious. Like, are they
there are
techs, senior techs? Who teaches this?
Right. So there is a dedicated, in the first batch, there was 2 teachers who also teach the surgical tech training program, but they also taught endoscopy. Then the second batch, we had a full-time technician who had about 20 years of experience. She taught them along with another part-time technician. In the third batch, again now third batch, they had 2 formally well-trained technicians who took up education. In addition to that, the industry reps come and teach them. That's another advantage. And what I would like to see is our own endoscopists, right? We teach so many people. We teach our own colleagues and trainees. It is good opportunity for us to actually go to the community college and teach these students, because you are going to make a huge impact on somebody's life there.
Absolutely. How does the course adapt to changes in technology? For example, I'll just give a couple of concrete examples, right? If new developments come out with new endoscopes, new processors, or for example, if there's multiple companies that make endoscopes, new technologies and electrosurgical generators, for example, things that kind of change the paradigm. How does the course adapt to this?
It's a very important point. I think without planning for that, this course can become obsolete very quickly.
Right.
So the way we set up is we want it to be neutral without being partial to one industry or not. So the way we set up the course material was using the illustrator to illustrate the concepts. When it comes to the hands-on training, the best trainers are either endoscopists or industry reps, right? Industry reps have a lot of knowledge. When we started on this journey, we wanted the community college to recognize endoscopists, technicians, nurses, as well as industry partners as equal partners in terms of who can come and teach.
Okay.
Right. That way, what happens is if you have a new device, right? If an endoscopist has time, they can come and volunteer. If an endoscopist doesn't have time, industry will be happy to do that. So
right. It's just a bit more partial, of course.
Right. They're more partial, but that's part of the game. And that is the way we set up so that nobody is excluded. In terms of the goal of this course is to train a technician that can help you with basic outpatient endoscopy, emergency endoscopy, and basic ERCP in the U.S.
I see.
You have a lot more than that, right? You have ESD, POEM, Barrett's, or U.S. guided therapy and advanced ERCP.
Right.
And those skill sets, I'm hoping that the younger generations can take upon themselves and create the material so that they can have advanced degrees or advanced education in different subspecialties.
Absolutely.
So that is, I'm leaving it to you and your colleagues to do that. Yeah.
No pressure, of course.
Yeah.
What is the future hold for this program? And along those lines, let me ask you this actually. This came to mind. This has made a remarkable impact in the Houston metropolitan area, right? But obviously, there are nurses and techs throughout the country. What's the future hold for the current program here? And is this is this a plan that's going to be replicated throughout the country in other community colleges? Like, for example, if a tech from, let's say, UCLA or a tech from Brigham and Women's, wants to go about a similar adventure, or similar, similar education, if you will, how do they go about doing this?
Yeah, I think that's a very important question. I will give you a little bit about how community colleges work.
Okay.
So, say for example, you are the president of a community college, and say for example, you're in California, and you feel that there is a need for developing endoscopy tech training program or offering that course in Southern California, say for example. You have two options. One is the hard option of the way we have done, right? Go through the steps, which is a wastage of time, right? It will take 7 to 10 years to make it happen. Or you say, let us look at who has this program available. And typically what do they do is community colleges honor community colleges requests.
Okay.
So they can reach out to the Houston Community College and say, hey, we want to start this. Can you help us? And they help your college to set it up. And they will say, hey, we will help you with the learning material and how we have done. And you may need to make your own contracts with the local hospitals. There has to be an endoscopy champion who can actually make it happen.
Right.
For the technicians to get the hands-on training. So this is what community colleges do. And before we started on this journey, we looked out and said, hey, are there any programs that we can copy and then implement? That it's much easier to do that. And at that time, when we Googled in 2016-17, there were a couple of programs on the websites in Google. One was in Florida and the other one was in Newark. And when we contacted, we didn't get any response. So we did not get any response. So that led to starting from scratch.
I see.
So that's one, right? Community college to community college. My personal goal is to make it available for anybody from anywhere to do this.
Correct.
Right? That's the goal. When you have a slide set and you keep it to yourself, nobody else will see. Right? When you keep it out, people will benefit. So community college to community college, that's one option. The second one is ASGE has the entire material, right?
Right.
And ASGE certificate is recognized by the Houston Community College, and they will give you the credits. And say, for example, I'm in Chicago or California. I go to become an ASGE associate member thanks to my endoscopists who are group members, and I go and take the test. And I pass the test. I come up with that, come to the Houston Community College, register, and get my credits. And then whatever remaining credits, I can finish online.
I see.
Right. The other thing is if somebody is a novice, doesn't have exposure to endoscopy technology, for that, there have to be local champions, endoscopists or therapeutic endoscopists, educators who are willing to work with their managers or the hospital system to create the training program, hands-on training program. So hands-on training program is one. Knowledge is one. Knowledge is already available.
Right.
right? The hands-on training, like we all train our technicians, right? When I have a new technician, we're training them technical skills.
Right.
Right. So that is actually possible. The other thing is our own institution, MD Anderson Cancer Center, started their 12-week program, intensive program, for the first time in its history. And they may be learning how to actually make it available to others. That's another thing that is in the works.
Right. Because I would imagine, one of the challenges would be if you were, again, for example, train a technician just starting out in California, you may not have the ability to come all the way to Houston to learn, right, or to get hands-on exposure. You just want to jump into your job in California, but at the same time, you don't want to hit that ceiling either, right? It's like, the whole point of this is to see if we can improve and give them a ladder, give them a career pathway.
Right. Right.
So I'm going to ask you a theoretical question, Dr. Raju. So we talk about how to make this program available, and how to take this model that you've created and make it available across the country to endoscopy technicians everywhere. Let's say I'm a young endoscopy tech and I'm training, let's just say Hawaii. And, I have a couple years of experience. I took on this job after graduating high school. I want to do something that I feel like is meaningful, that will, help pay the bills at home as well. But, now a couple of years in, and I really want to grow in my career, and potentially, try to get promoted, if you will. How do I take advantage of what you've created? And or what would my endoscopists that I work for, what would they have to do to get me over this next bar, if you will?
So, Phil, when I see that type of mentality, I get excited.
Yeah.
Right? You want to grow, and we want you to grow. That's the most important thing.
Correct.
Previously, there was no pathway. Now there's a pathway for anyone out there to grow professionally in healthcare. So first step is there are 3 requirements that we need. One is you should have a minimum of 4 years of experience in endoscopy, and your endoscopist or endoscopy nurse manager has to sign off saying that you can assist endoscopy procedures, EGDs, colonoscopies, basic ERCP, basic US. So certificate. The third component is going to ASGE and completing the ASGE test of certificate of completion. You can take the test. If your group of endoscopists are part of a group member, you can take the test for free. On the other hand, if they are not, you pay a nominal fee, about $150, and you take the test. And you submit your experience, your letters of support from your endoscopy manager and endoscopist, and your ASGE certificate, including the transcript that they give you, to the Houston Community College. You have to register to the community college as a student first and then submit these.
I see.
That will, once they go through, review the material, they will give you a significant proportion of the 35 credit hours required, almost more than 50 to 75%. I don't know the exact number, but a significant proportion. For each course, you pay a nominal fee. So that's not going to cost more than $300 or $400. So the remaining courses, that medical terminology, human anatomy, human physiology, that's required, can be completed online.
Okay.
Staying in Hawaii, and submitting to the community college that you completed the online courses, and then you can graduate with a level 2 certificate. Level 2 certificate with 35 credit hours from Houston Community College.
Uh-huh.
If you add another 30 credit hours, you will obtain associate degree with specialization in endoscopy technology. So say, for example,
From the Houston Community College.
From the Houston Community College. And say, for example, I started after high school, but I want to grow. And I'm as smart as anybody else out there, but I want to grow. What would I do? And I don't want to waste a lot of my money going to university. So I would join and then go through this process, get level 2 certificate. Then if I have interest in BSN, my associate degree courses, I will try to plan to take them that are relevant to be a nurse. So I'll get my associate degree. And right now, there is an opportunity to get bachelor's degree with business administration right now at Houston Community College, going this pathway. That means if you get that, you can actually go the pathway of an administrator inside your hospital with business administration and then doing your master's in business administration. In the future, the community college is looking at from the associate degree to go to BSN.
Right.
That pathway is being currently developed.
I see. And so this is available to basically anyone in the country because of because of the ability to take courses online and therefore to get your degree essentially through an online education.
Yes.
Because I would imagine it's not easy to go ahead and replicate and reinvent the wheel locally at every community college.
Right. The key players are your own institution,
right?
Your group supporting that you have experience and you built that experience. Community college providing a platform, and the Houston Community College recognizing ASG certification of completion.
Right.
That's actually a huge thing, because I felt that, hey, if I were in Chicago or Milwaukee, I want to do this.
Right.
You know, I can't make it to Houston, but the community college leadership recognized that give importance to the ASG certificate, and that's an external validation. All the current students who are going through the formal program at the community college, they've gone through every year, and then by the time they graduate, they have to take the ASG test.
Right. The formal curriculum that's physically present at the community college, therefore, that's geared towards those who really have nothing coming in, who don't even have a job coming in, basically.
Right.
Okay. Yeah, so that in itself, Raju, I believe that is really the historical achievement here, right? To give this opportunity not just for those in the city of Houston who are trying to become techs, but anywhere around the country, whether they are new techs, junior techs, or even senior techs, to give them that sort of recognition and give them that sort of career pathway. I think that is the true historical achievement here.
Right.
If I may say.
One thing that I want to share is Houston Community College is supported by the Harris County. If you are living within the Harris County, your fees is a little bit low.
Sure.
If you are a little bit outside, it's a little bit high. And if you're outside the state, it's a little bit higher. So that, it applies to, any community college anywhere. But otherwise, they have done an amazing job. I thank the president, Dr. Phil Nicotera, and Dean Jeff Greikar from Houston Community College for recognizing the ASG certification of completion.
Right, and I think with regards to the out of state or non-local tuition, I think quite honestly, if you're a promising young tech, even from Hawaii, I think it's within the responsibility of us as endoscopists to be able to support you to
Right.
to do
Right.
this.
Right.
I personally would.
Right. Right.
Yeah, and of course every person is different in terms of how they how supportive they are, but I think it's part of our responsibility as
Right.
endoscopists, ESG members, etc.
Right. Right.
Very good. So it takes a special person like yourself to do something like this, Raju. Tell us a little bit about yourself as a person. You're revered in our field for really your spirituality, your kind of your way of kind of seemingly being above all the chaos of daily life. You kind of transcend this sort of hustle and bustle of daily medical practice and daily life. All your technicians in the room, they always either talk about or joke about how the music you play in the endoscopy room is kind of like being in a temple. But tell us about your mentality and approach to endoscopy and your approach to life.
So I play Native American flute. That's what I play in my room. One instrument. And when you want to really appreciate anything, it's best to see or hear it in a very pure form. And I personally feel that there is a lot of wisdom in the Native American culture, and also in different cultures. At the end of the day, we are all influenced by our family and by our mentors. I was very lucky to have exceptionally kind mentors, right? And I feel that as physicians, we take care of patients, and we all have a great opportunity to do something on the side. And this basically bothered me for some time. I thought that, okay, why not? And I was very lucky to have a fantastic group of people to work with. Whatever happened, I want to make sure that I share this.
Mm-hmm.
This could not have happened without so many people,
right,
pitching in. Right, the different people pitch differently. At the end of the day, the final whatever the building is the reflection of so many people's hard work. And the timing was great. I was able to work with the community college, Anderson, philanthropy support, and our own team of nurses, technicians, and fantastic industry partners,
mm-hmm.
and the ASG. Right, it's so many things just happened. I just enjoyed the ride.
And there's a particular, I remember there's the signature in your email is a particular quote that you live by as well. Tell me about this quote.
I grew up in India, and the quote that you are mentioning is hands that serve are holier than lips that pray. So that's a quote from Satya Sai Baba. A lot of people believe he's a reincarnation, and I will actually send you a link for you to appreciate. He believes that your hands do the work.
Mm-hmm.
Your hands can serve, right? And for some reason that has stuck in my mind, and I like that quote. For whatever reason, I cannot give you a detailed explanation. In my own life, we all go through tough times in life, and
right.
There's no life without having tough times. And that quote and Sai Baba actually helped me deal with issues.
Yeah.
I will send you a link. Send you a link.
Very good. You're widely known, in fact, along those lines, that, hands that serve, you're known to be a very selfless mentor. You've given advice freely. You've given education freely. You give opportunity to junior colleagues like myself. You give opportunities to staff, never expecting any sort of repayment. It's a rare and admirable personality in the world that we practice in and in the field that we practice in. Were you always like this since you were young, or is this a quality that was inspired and nurtured? Where does this come from?
I think many people helped me along the way. I think when you are the beneficiary of support and help, I think it will automatically mold you. So,
you hope so, but not everyone sees it that way. I think it's actually quite uncommon that you're like that. That you're this uniquely altruistic.
I'm not sure about that. It's a big term you're using. So, yeah, but yeah, it's. I left the country quite early. I left home quite early. And I left home at age 21. I think that's a little bit unusual for an Indian to leave. And along my journey, I think many people have been very kind, very supportive. Sometimes this support comes from totally unexpected people and places, even as simple as joining MD Anderson. I never thought that I'll be at Anderson. I never thought I will be in Anderson. Thanks to Dr. Mendelson and John Stroline. It's
and neither did I, thanks to you and John Stroline.
You are a blessing to us. All right.
Well, thank you again, Dr. Raju, for a very wonderful and very deeply insightful interview. I asked this to everybody that I've had the pleasure and opportunity to interview, and that is that to close out, I'm going to ask you for your personal advice and wisdom. What advice do you have for future generations who wish to become as innovative, as insightful, as forward-thinking as yourself?
I think you have been too kind to say so many things, but I don't know whether I fit the definition. I'll put it this way. I think most important thing is each one of us needs to know what we want, not what somebody else has. We need to know what we want and what we want to do with whatever time we have. I was just looking at the other day, what's the average lifespan? Instead of years, if you really count about in days, it is about 28,000 days. 28,000 days. It's like a car service that comes by 30,000 miles. So very important to not only do the job that you need to do to put food on your table and take care of your family, but also important to constantly be on the lookout to learn something new and exciting, and not be afraid of expressing your views. You should make sure that you don't compare with others. God gives gifts to different people in different ways, but God also puts in some problems that you may not know what others are dealing with. So, So best thing is just enjoy the life and do good, whatever you think is good.
And just be yourself. This is like It's exactly like the advice that was given to me in my intro to you.
Yes.
Thank you again, Dr. Raju. It's absolutely been a pleasure. We'll look forward to seeing this come out to coincide with Endoscopy Text Week. I look forward to seeing this. Thank you very much.
Thank you.
Thank you. Thank you.